All right, Alec. You know what? I wanted to start by saying that I was talking to one of the guys this yesterday, and this study session is from um in 2021, I think it was. I was offering study groups to like the public or whatever. I stopped doing that because it was stressing me out. So these PowerPoints, some of them are from that time period. And so I know you guys know me, but I was thinking about that PIP on the back of my name. And one of the guys says we were talking in supervision recently, and that PIP is even more important now because Alabama law changed last year. I don't know if you guys know it, but in order to do a home study in Alabama for adoptions, you have to have that PIP. And so, if anybody's interested after you finish your clinical supervision, I do have like a 6 week get your PIP if that's a thing because with Alabama law changing and only the LICSW PIP being able to do the home study, I got reached out by attorneys' offices and family members to do the home studies. I'm not doing them, but I can at least help you get to your PIP. And if that's something you're interested in doing, just so you'll know for later on. All right. So the way to get started is to quit talking and begin doing. And that's what we're doing today on this Saturday. We are here and we are doing it. One of the things, if you were there, and I'm going to be uploading Renee's presentation after we get done today. But one of the things, if you were there for Renee's presentation, I was thinking about this like, you know, not just even Renee, but we heard from Renee, we heard from Tierra, we heard from Malikia. You know, we could even y'all are going to hear from Tanessa. We can talk and talk and talk about we're going to do this thing, but until y'all start showing up in some tangible way for yourself, and it could be this, or it could just be your own study processes. So you showed up, right? And why this matters today is that what we heard from Renee is the ASWB exam can feel overwhelming and actions break through fear. So you're taking action today. And today we're not just reviewing, but we're practicing. And I love practicing. It's more important to me to practice the test than to review the content. So that's what we're going to be doing today is practicing the content. The other thing that I wanted to make sure I pointed out, I love that Renee talked about um, not changing your answer. And so I want you to practice that today as well, even though there's other goddesses on here with us today. I think somebody's here. Even though there's other goddesses with us here today, um, I want you just to try to start trusting your intuition. Whether you get it right or not, we're going to practice that process of, I think,
You know what my
and
plug looks
then,
like?
hi, Krista.
I'm sorry, I was talking to my daughter. Let me mute myself.
But I want you to begin practicing trusting your intuition, saying, this is my first response, and just going with that one and see whether you get them wrong or not. See what that looks like and what that feels like, where the answers are showing up for you, what thoughts are coming in your mind when you're second guessing yourself. Let's be aware of being able to trust yourself that you guys know this material. I think Tiara said it, Malikia said it, and Renee said it. Y'all know this stuff. And so I want us to practice trusting what you know. Okay. And then what we're doing today is we're not just talking about it, we're being about it. We are doing the thing. So I already talked a lot about this because it was important to me. Your first instinct is your best instinct, right? So if you picked an answer confidently and you start doubting yourself, I would love to see you guys pause, breathe, and then move on. So when you are on the exam, even today while we're practicing, if you pick an answer, pause, breathe, and move on. That's all you got to do. Okay. Um, and let's practice that today. But why? Because your brain has already been preparing for this. So you trust your trying to trust yourself most wrong answers, and I was reading this, I don't know what article I read this in, but most wrong answers come from overthinking or second guessing. And unless you realize you misread the question, don't change your answer. I know that I took the test a long, long time ago, but I do remember, and I've heard some of the goddesses say over and over and over again, or when they're saying this, this is what I remember, this is what I recall. While I would be taking the test, and maybe even while y'all have been practicing taking the test, if something came up in another question, I'd be like, oh yeah. And then that would make me think to go back to that question. So unless again something comes up and you're like, oh, I didn't think about that, or that's the answer, or if the first question that you were doubting, you just didn't understand the wording or the context, and you see it later on in a question, and that triggers you to go back to answer that question differently, that's great. But unless that has happened, know that you can trust your training and you can trust yourself. Okay. All right. So this is how we do it. And for those of you who've been here, you already know this is, well, first, I'll say this. I think that there are four big categories. When you go to the ASWB exam site, you're going to see like 5 or 6 pages of all the different content that shows up in the exam. And I can't remember which goddess recently said it. It might have been Renee, but there's no way to be prepared for all of the things that could potentially be on that test. But for me, there's four big areas. Human behavior and development. I know they changed it to human development, diversity, and behavior and environment. So if you have those two books, your HBSC 1 and 2 books, go and look through them, once a day or once a week. Read a couple of pages, read 10 pages through it. But human behavior and environment, assessment and intervention planning, interventions with clients and client systems, and then professional relationships, values, and ethics. Those are the big content. So if you can do your HBSC, what are the developmental stages through the lifespan? What are the assessment and intervention? Assessment is the DSM. Intervention is what are you going to do once you got the diagnosis? Then obviously they have interventions with client and client systems. That's not just the client, but the family, the community, and the agencies and organizations, including our government, and then our own professional relationships, values, and the code of ethics. Okay. All right. So, how I break down the questions and how I'm going to ask you guys. And remember, if you've gone to come to any of the 3 sessions we had today with the goddesses talking about, all 3 of them use different ways and different techniques to practice taking the test. No one's saying either one of those are right. It's what worked for them. What worked for me and what I've always taught is it this way. And for these purposes, we're going to use it this way. But when you are studying on your own, do what works for you, right? Do what works for you. But for us to be able to do this and have some structure within our community today, we're going to do it this way, okay? So we're going to look at the question stem. The question stem is the last sentence of the question that is being asked. Go directly to that. In fact, if you can train your brain, train that beautiful brain of yours to go straight to the question stem, that's what I want you to do, because we got to know, what is this question actually asking? It's going to give us a lot of fluff. It's going to probably even give us a lot of good information, but we still need to just know, what is the question asking us, because we'll read something in the question and we're like, oh, it's about this. And it may not be. So one, go to the question stem. Reason I tell people to go to the question stem first is because it slows you down a little bit. One, we want to look at what the answer choices are, right? I don't want you to look at that yet. Don't even look at the answer choice, because that will create a bias when you're looking at the question. So again, going straight to the question stem. Don't look at your answer choices yet. Don't look at the question yet until you look at the question, because again, you might create a bias about, oh, this question is asking this. This slows you down a little bit and diminishes the potential for you to create a storyline about what is being asked. Then, after you looked at the question stem, I want you to read the question in its entirety, right? We're going to practice today, but read the question stem, then go back and read the question in its entirety. When you read the question in its entirety, then you pull out some keywords, okay? After you pulled out the keywords, and we're going to practice this, look at your answer options. You see, looking at the answer options, which is A, B, C, and D, or A, B, and C. Now the ASWB has these three answer choices. We don't do that till step 4, right? You see how we're slowing ourselves down? We don't even look at the answer options until step 4. Once you've looked at the answer options, let's get rid of 2. But we're not just going to get rid of 2 because it just doesn't sound right. We are going to talk about what is the rationale behind why you're going to get rid of those 2, okay? And then once you get rid of the 2, you're going to pick the best of the 2 answer options. And if it's a 3 answer choice, which I do not have any of those in this presentation, but on the ASWB exam, and I hope some of the newer questions that you guys are studying, there's 3 answer options. But either that means that's the answer, and what is the rationale? And or you have 2 answer options left, pick the best of the 2, and then give me the rationale as to why you did. Okay? Whew. Any questions so far? See y'all's beautiful faces. I know we just got a couple of new people. Y'all who've been here with me, we know how to do this, okay? All right, so here we go. We're going to practice. What did we say first? We're going to look at the question stem first. So the question stem is, as a mandated reporter, your next best step is to, okay? As a mandated reporter, your next best step is to. Just looking at that stem, what does that say to you?
Get in the mindset of a mandated reporter.
Good job. One more thing it says.
We're looking for the best answer.
That's it. It's not the next thing. It's not the first thing. It is truly the best answer. Okay. So now we're going to read the question in its entirety. You are a school social worker called to a teacher's room because they have a 6-year-old child who has scrapes on his knees and shins. At the classroom, the teacher says this is not the first time the child has come to school with scrapes on his legs. As a mandated reporter, your next best step is to. What are the key words in this question?
The age of the child.
6 years old. What else?
The fact this is not the first time.
And I think that the teacher, I think the teacher is important because the teacher is also a mandated reporter. Do y'all remember that? Teachers are also mandated reporters. Okay. So we read the question stem, we've read the question in its entirety, and now we pulled out some keywords. Now, step 4, we'll look at our answer options. A, make a report to Child Protective Services. B, contact the parents and request a meeting. C, question the teacher about past incidents. Or D, ask the school to provide medical evaluation. What 2 can we get rid of?
D.
Why are we getting rid of D? And who said that, Quinn? Why are we getting rid of D?
I didn't
I
say.
said, oh, I said it because
I'm sorry. Why are we
uh,
getting rid of D?
I would think, what are we asking? First of all, we don't have, we can't just go in there and get the child's medical information without a release. And I don't think that's pertinent to the situation.
Perfect. Good. What other one can we get rid of? Good job, Krista.
I was gonna say A.
A, okay. Why are we getting rid of A?
I was in A because we don't have additional information to report. So I think we need to assess the situation first. And then if it gets to a point, then we'll get to that point. But I don't think it's the best next thing to do.
Good job. Quinn, when I was looking at this question, I was thinking about you. So I'm so glad you piped up. Good job. Good job. So we have B and C left. contact the parents and request a meeting, or question the teacher about past incidents. B or C. Here we're going to just go to, what do you think is the best answer out of B or C?
I think it's C,
Why do you think it's C, Krista?
because I think in your assessment, it's just the natural next flow when you're trying to assess the situation. To me, that would be, but I know we're not going with like naturally, but because like they say, you're not supposed to be putting all how you would do it. But if you're trying to figure out what's going on, you would ask the teacher, because she mentioned that there were previous incidents. So she's aware of those. So you're trying to get all the information.
I love it. Okay. Anybody have something more in or different?
I could add on, being a school social worker, I was looking at, it's a 6-year-old. 6-year-olds always fall and scrape and play around. They're really rough. They're on the bus playing hard. So if the teacher says that it's not the first time, the teacher will be able to give us additional information on the scrapes of the legs. And then I guess after the fact we get that information, we can go into the other answer choices.
Mhm. All right, so right now we have 2 for C. I would like for you guys to put your answer, the rest of you, and all of you actually, put your answer in the chat for me. Going with your first. Quinn C. Carissa, you have something different. Carissa, I'd love to hear from you. Why are you thinking the answer is A?
Well, initially, I thought that since the teacher already provided information of it, and we're always taught it's not our job to investigate, I just went with A to allow social services to do the part. So that was my assumption.
And you know what, Carissa, I appreciate that, because we are, right? But how I took it when I was listening to you just then was like, well, then the teacher needs to make a report. Because that's why I was like, the teacher is also a mandated reporter, right? And so I'm still not going to make the report to Child Protective Services. If the teacher has all the information, the teacher should be making the report then. That's how I just took what you said. Katrina, you have a thought? Or are you just unmuted, babe?
Yeah, I didn't even realize I was still unmuted. I don't
You're
have.
okay. All right, so let's see what the answer is, you guys. It is C, yay. And let's read it. You are in information gathering mode. Scrapes and cuts on legs are very common for children of this age. You should not become worried unless there are many other identifiable facts. Gather as much historical information as you can. A is incorrect. You do not have enough information yet to do this, but how I'm still sticking to how I was explaining to Carissa. And then B is incorrect. You need to gather information from the on-scene resources before looking at the parents. And then D is incorrect, not yet. You are not even close to this level of intervention currently, which was that medical evaluation. Do we have any questions about this first one? How y'all feeling about it? How are you feeling about the format we're using?
Well, I wanted to say that it made me slow down because it says best, and I was thinking with the next step, like going into, okay, this is what you do next, but it says the best one. So that's different. So I got to make
Mhm.
sure I think about that.
And I love that, Chris, especially since we've been talking about that a little bit in supervision, how social workers are so solution focused. And so we go straight into solution versus, like you said, slowing down a little bit and thinking about, well, what would be the best thing to do versus what would be the quick fix of things, right? Yeah, good job. Good job, y'all. Very good. Any other thoughts before we move to the next one? Y'all feeling all right? That's my baseball mama country slang coming out. Okay, let's go. So here we only have the one sentence. Well, I guess two. You are finishing your work with a client. As you begin the process of termination, your primary goal is. And so here with the STEM, I would have stuck with your primary goal is. So when we're looking here, your primary goal, what does this say to you? Anybody?
It's the main purpose of what you're doing while terminating.
I love it. Good job. All right. So now I'm going to read the question as entirely, even though I already did. You are finishing your work with a client. As you begin the process of termination, your primary goal is. So what are our keywords?
Process of termination? Process?
Termination is definitely a keyword.
Primary.
Yeah. Again, primary is a keyword. And termination and finishing to me are similar. So the energy of this question is you're finishing your work, you begin the process of termination. And so what is your primary priority goal, right? So then our question options or answer options are have the client give you feedback on your performance, ask the client how they feel, summarize the progress and goals you have achieved, determine referral needs. What two can we get rid of first?
A,
Yeah, I was going to say the same.
I didn't hear either. Wait,
A,
one more time.
A,
A, okay. Get rid of A. Why are we getting rid of A?
because the primary goal is not to focus on my performance.
Who can give us that? The client. Yeah, that's not where we get it. Yeah. All right. What other one can we get rid of? Go
I
with your
would
first gut.
I
Go
would get
ahead.
rid of C. Not that C isn't important and part of the termination process, but it's not the main purpose of termination as far as making sure the client's in a good spot when you leave them.
Okay. All right. Anybody have anything different from that? All right. So we're left with B and D. Out of the B and D, ask the client how they feel, or D, determine referral needs. What is the best of the two?
I would say B.
B, ask the client how they feel. Or why would you say B, Krista?
Because I just what comes to mind is sometimes they're not okay with termination, but you still have to terminate, but you want to see if they're able to be terminated, I guess, or if it's not a good idea.
Okay. Anybody have something different?
I would say D.
Why would you say D?
Because I feel like all of these, not A not as much, but all of these are part of the termination. But the primary goal is to make sure that your client is stabilized as you're ending services so they don't, right? If I have an active addict, I'm making sure, okay, it's your AA program. This is who your accountability buddy is. I'm making sure that they're stable, that when I leave, it won't completely dysregulate and right, make my client really unstable. So although I think all of it's really important, I think making sure any needs outside of my services are met as I'm walking out the door is the primary, most important part of termination.
But I thought that I understand what you just said, Jackie, but I thought, well, typically, again, I'm putting myself, so I don't, I guess I'm thinking, but if they don't, I've had clients that don't want to be terminated, of course, but we have to. What if they say they don't want, it's not working for them, or they're not stable, is what I'm saying. What if they're not stable?
Because I think you're putting too much in there, babe. Because we're finishing our work with the client. And we're
Yeah.
at termination, so they have, the stability is it, your social worker stability would be assumed. One of the key words I don't think we said is begin. This is the beginning of the process of termination. If we look into that word, begin with priority, does anything change for you guys? You guys can all go ahead and put your answer options in the chat for me.
What if my answer
Um,
choice is something we already eliminated?
Yeah.
I want to hear that. Yeah, let's talk about it. We're gonna all have different answers, I think.
I was thinking that the answer would be C, since I'm thinking about the beginning of the termination, and we're
Mhm.
summarizing goals and progress to make sure you achieved everything we would set out to. So now we're at termination. We making sure everything is achieved to terminate. So that's why I thought it was C.
And I think if
I
we start with that, there's a couple things I'm thinking, Natasha, thank you for that. If we start with that, Krista, that will help you to help the client feel stable. Like, oh, we've summarized the progress and go and look how much you've achieved. Then they're going to be like, oh, wow, even though they don't want to, you giving it back to them as it relates to this is, this is what your progress has been. These are all the goals that you achieved. You're empowering them versus continuing to enable them.
Well,
Right.
see, that I guess go with your first answer, because
Mhm.
my first answer thought was C when I
And let
first
me
read the
say
question.
this, I waited a long, long, long time after Jackie eliminated C, and not none of y'all jumped in to say that that was your first gut.
Well,
I
Jackie's so
waited,
knowledgeable,
and
so
that's one of the reasons I love doing this stuff as a group, because I want you guys to see how easily swayed you are. How easily swayed you are. Y'all see what you do? You're like, I felt it was C. Oh, sorry, my mouse is super. Um, how can I go back? So as you guys can see, it is C. It is C, and I'm gonna try to read it so we can get it. At termination of the counseling relationship, your primary responsibility is to summarize goals and achievements. Remember, termination may occur because the client is ready or their insurance plan is done paying and they do not want to continue. Other factors is blocked a little bit come up and they need to put their time and resources elsewhere. A is incorrect. And what was A? Have the client give you, okay, we already knew that. We don't have to go through that. B is incorrect. You should be asking the client how they feel continually during therapy. There is no specific need to start or stop this process during termination. And D is incorrect. This should have been done in the beginning, and referrals and linkage should be completed during therapy. If the referral has not been successful, you may want to follow up. If the termination is unplanned, you may want to follow up. However, your primary objective is to summarize goals and objectives. And I want to talk about that a little bit too, because you remember my favorite phrase is you can only take the client as far as you're willing to go. This speaks to me the fact that we were ready to jump ahead and not even consider summarizing is how are we slowing down and looking at what we've accomplished and what progress we've made ourselves. So when we practice that for ourselves, slowing down, what progress have I made? What goals have I met? We can easily do that also with our clients as well. I think we're always so quick to jump to and Krista started this. What is the next solution I need to do for this person? What is the solution? Versus we've already done a lot together. How can we slow down and review that process? Do we have any questions, thoughts? That was fun. All right, let's go to the next one. Try to move stuff around. Here we go. During her description, which if the following behaviors are not considered appropriate. So we don't even know what the question stem is. We know that there's a description. Which of the following behaviors are not considered appropriate? When you guys are seeing that, what's standing out for you? Without reading the question, without reading the answer options, what's standing out for you?
The word not.
Mm-hmm. What about it is standing out?
One is all capitalized, so it may grab my attention. But it's when I read those type of questions, my brain says what's all included except one
Mhm.
thing. So I'm thinking about three things are what the behavior is supposed to be, and then one thing is an outlier. So that's what I came to the conclusion with it.
Perfect, Quinn. So even though we've been looking at two and getting rid of and with rationale, this time we're going to include three that are appropriate and get rid of one. Okay. So now we're going to look at the question in its entirety. I hope that you are training your brain not to look at the answer options because I don't even know what they are yet because I have not looked at them because I have trained my brain to go to the STEM. And now we're going to look at the question. You are working with a new client who has just come into your office and has begun a very detailed description of the events which have culminated in her current crisis and the need for your services. During her description, which of the following behaviors are not considered appropriate? I love this. This is so vague. We don't even know what she's in here for. We don't know what type of, we just are knowing that somewhere in these answer options, we're going to know something that's not considered appropriate. So, what are our key words with this question?
New client.
Good job. Uh-huh. Why is that important?
Because you will be doing your first this is your first time meeting this client, so you're gathering a lot of information. So it's just like you don't know what to expect. So you're starting from the top.
Good. Good job, Quinn. Is there anything else that anyone wants to bring up?
She's in crisis.
Good job, Carissa. She is in a current crisis. That's why she needs our services. All right, let's look at our answer options. When she is done speaking, summarize everything she has said. Use body gestures like leaning forward and nodding, encouraging her with phrases like go on and uh-huh, interrupting her narrative when you feel the need to clarify details. I think this one is pretty.
Mhm.
So, what three do we include and which one do we get rid of? Put your answer options. Put your answer, your final answer. We'll just do it like that. Put your final answer in the chat. Okay, we got two for D. Did we need more dialogue about it? Okay. Who said
I did.
All right, Quinn. What three? Okay, let's say what two would be appropriate, considered appropriate working with this new client?
B and C off the rip.
We're gonna use body gestures like leaning
Mhm.
forward and nodding. We're gonna encourage her with phrases like go on and
Mhm.
Does any say it. I love how confidently Jackie said, you go girl. Jack. Anybody disagree with keeping B and C as appropriate for
I would
this?
A and
Uh-huh.
B.
A and B, okay. When she is done speaking, summarize everything she has said. But what I'm hearing, or from that, A, B, and C, we still have D might be inappropriate.
I think I'm stuck because if I don't understand what she's saying, is it not okay for me to interrupt to get clarity so I can follow along so I'll be able to summarize? Or am I reading too deep?
No, because I'm having the same problem. Because in practice, and this might make me a bad social worker, but in practice, I'll stop and I'll go, oh, when they use a jargon or something I don't
Well, I
understand,
do
I'll
the
stop
same.
them and I like clarify in real time. So I feel like in real life, I would stop and clarify as we go. That way I can continue to hold the conversation and understand and create right complexities in the story. but maybe I'm thinking too much, and my brain goes, they're probably not going to want me to do that. I should summarize everything when it's said. But even in real life application, I feel like if she's in crisis and she's just trauma dumping on me, summarizing everything I'm going to say, she's going to say so much, I'm not going to grasp everything.
Right.
So it creates like a loop. But I'm stuck between A and D personally.
Same. I'm gonna put my answers in the chat.
I love
I
it.
I chose D because she's a new client, so I don't know how well she'll take to interrupting at that time, especially if she's in a crisis. And I said summarize at the end because that way, if I get the totality of the summarization, she can go in and correct. But that's just my thought process.
And I think both are important, Jackie and Quinn and Carissa. I think because she is a new client, it's the first time she's told the story. And so just let her get it all out. Let her get it all out. And the summarization does not have to be as, I love this for us right now. I love this teaching moment. The summarization does not have to be in 1997, Bob came into your house with a red key and opened up your pink cabinets. Like having that kind of detail because you're trying to remember every single important detail. I think, especially with the new client, the first client, we just want to sum up the energy of it all. Like, that sounds like that was really difficult. Are you following me? Like, that sounds like, man, you've overcome a lot in regards to allowing her to just tell the story. And one of the other things that I've learned, and those of you who've done the ASAM, is 13 freaking pages, right? Yeah, Clint, you know the ASAM is 13. Let them tell their story because it's so much more fun, I think, as a social worker, to let them just tell the story and then you pick out the pieces instead of trying to stay on this uh chronological or a specific pathway of getting the information that you want to get. I do think that the details, one of the things that I have witnessed is that the details eventually come. Eventually they'll get to the detail of the thing. And sometimes the interrupting is, I want to say like this, is instead of them being able to be in the flow of that uncomfortable emotion, we might start feeling some discomfort. So we want to jump in instead of just practicing sitting in the discomfort of how this thing is for them, practicing that for yourself and for them, modeling that for them as well. Okay. Especially with a newer client. You're not a bad social worker if you do. I interrupt y'all all the time. you're not you're not a bad social worker if you interrupt narrative. I think though with the new client, you want them to just be able to tell their story and not get off track of what it is they want to say versus us trying to lead the conversation and what it is we need out of it. So let's look at the answer. Oh, did y'all give y'all's answers? I think you did. We had some for A and D. And I can't see. The answer is D. Interrupting during a narrative runs the risk of distracting the client and knocking her off course. In this scenario, she is given a clear and detailed narrative, and you should be listening actively and taking notes. When she is done, you can request clarification on several items if you feel the need. Summarizing for a client is always a good thing. It lets them know you're listening and lets them know you understand their situation. It could also be used as a technique to elicit information. If you summarize what you heard and you get it wrong, it can alert the client to things they did not report or relate or they need to clarify, right? I love that part. B is incorrect. 93% of all communication is either nonverbal or paraverbal. You can transmit a tremendous amount of information in your posture, in your gestures, in your facial expression, and your tone of voice. The more body language you can use and can read, the easier the session will be. And I will want to add, that is why when we sum up something, instead of details of it, you can sum up the energy of it. This is, oh man, what I got from all of that is this, right? Because a lot of it also the client is giving you is nonverbal and paraverbal as well. And then C is incorrect because little phrases that allow the client to see you are actively listening and trying to keep up with them are very important. If your client perceives you as interested and actively involved, you should have a better outcome in therapy. We have any questions or thoughts about that one? How are we feeling? How's everything going? Are y'all liking this okay? Are you glad you took your Saturday to be with the goddesses today? Yeah. Good. All right, let's go on to the next one. I can. All right. Question stem. Which of the following is not one of these 5 categories? When I read the question stem, what are you getting from that?
Recall question.
I love that. Okay. Who said that? Because I don't see you guys.
It was me, Quinn.
Quinn, a recall question. Give us more for people who I get what you're saying, but for people who may not get what you meant by that, what do you mean by this is a recall question with which of the following is not one of these 5 categories?
So, basically, like a recall question comes from like information or how can I put it? Things that you have seen in social work, like the criteria of or the diagnosis or something, or like Eric Erickson, it'll get that information, something they think you're supposed to know.
Something you got from your training. And this, it sounds like something you got from your DSM-5 training. All right, I'm gonna read the questions. Quinn, actually, can you read the questions entirety? I just drank some orange juice and now my mouth is a little.
Yes. Criteria B for acute stress disorder requires the presence of 9 or more symptoms from any of 5 categories of response. Which of the following is not one of these 5 categories?
All right, what are our keywords? Thank you, Quinn.
Acute stress disorder.
Mm-hmm. Mm-hmm.
So we would have to remember what acute stress disorder is.
Yes. Okay. Does anybody remember? I'm not gonna raise my hand.
It's I believe 6 more months or 6 more. Oh, what are words? 6 months or less from a traumatic event that is like something that actually bothers you versus it being full out PTSD.
Good job. Mm-hmm. Did you want to add something more?
I had some thought blocking just then, so
That's okay. Did anyone want to add anything more? And if you don't know what acute stress disorder is, this is a good time to put it in your notes. Let me go back and review that, right? You just have to, you can either go to a YouTube video this week. I want to challenge you. Go to a YouTube video and listen to it when you're cooking or in the car. Read it in your DSM-5, read an article about it, like really try to integrate what acute stress disorder is. I was going to pull it up on the web, but I'm not going to do that because I want to make sure we get to all of our questions. But if you're not sure what it is, this week I want to challenge you to go and look it up, okay? In different modalities, video, reading, articles, TikTok, whatever the modality is, find acute stress disorder, and get it in your system. All right. So the answer options are what we know. Which of the following is not one of these 5 categories? Intrusion, dissociation, confusion, or avoidance. And we're not trying to make you remember everything. This is a good time for you to go ahead and look it up if you wanted to, so you don't have to guess it. And once you do, come back and tell me which two are we getting rid of?
So I think it's probably pretty safe to get rid of intrusion and probably avoidance because they match together.
How do they match together? I wasn't expecting that last part. How do they
So
match together?
if I say I have a car accident and I'm experiencing acute stress disorder because of it, I'm going to have intrusive thoughts about the car accident and about the events leading up to the car accident, which is going to make me avoid the car or anything that's going to trigger, right? We're using polyvagal theory on this one, right? Trigger anything that's going to remind me of the intrusion of the car accident. So the two kind of go hand in hand. I'm feeling a big response, so I'm avoiding anything that's going to create that big response.
Good job, Jackie. Thank you for that. Yes. All right. So then we have, oh, did anyone have want to disagree with A or D?
So if what we're saying is that that's a part, like we experienced that, right, Jackie?
Oh,
So
sorry.
wouldn't it be like not, like the keyword I see is not. So if we're saying those are in there, then would we rule those out?
I think this is like that last or the one we did with the not. Yes. And I love that you said that, Carissa, because not is not capitalized or bolded in this, right?
Mhm.
And so intrusion and avoidance, the way Jackie is setting us up with this not being here, is that is a part of criterion B for acute stress disorder, intrusive thoughts and avoidance. So then that means, is disassociation a part of criterion for acute stress disorder? Is confusion a part of criterion B for acute stress disorder? Does that help with how we're answering this? It didn't, or it did?
I think it did, because I think when, even if we go back to when we deal with people with traumatic experiences, even if we're not talking about full-blown PTSD, we do know like sometimes they do disassociate during
Mhm.
the act. So that's why they can't tell us necessarily exactly what happened. And then intrusive thoughts happens a lot. And if we think about like combat vets, they avoid loud places and situations.
Perfect. Perfect, perfect, perfect. So I said perfect because she's right. So what does that leave us with? And you can put your answers in the chat because Carissa is absolutely on it. Y'all did good with this one. Let's see. But did anyone have a different thought? I'm gonna tell you the answer is C without us going and looking. Maybe we already did look because I accidentally, but did it? This is a good time. This is where we practice. Anyone have a different thought about, oh, I thought it was going to be this? Okay. So the answer is C. Going back, which of the following is not one of the five? Confusion is not one of the five. Criterion B for acute stress disorder requires the presence of 9 or more of a total of 12 symptoms from any of the 5 categories of intrusion, negative mood, disassociation, avoidance, and arousal, beginning or worsening after the traumatic event or events have occurred. And you can find this on page 280 through 281. Again, I want to challenge and encourage you to go back and pull up your DSM-5 TR and read it so you can really internalize the answers today. Okay. Any questions or thoughts about what we're doing? Just checking in. Does anybody need a break? We've been on for an hour. Do y'all want to take a 5-minute break? You're like, no, let's do it. All right. What if I need a break? Let's go. Let's go. All right. I love it. I love that y'all are with me. Which diagnosis best fits this clinical picture? Which diagnosis best fits this clinical picture? Reading the question stem, what are we getting?
that based off the symptoms that are presenting before the last sentence, we're supposed to use our knowledge with the DSM to find the best diagnostic, I guess, criteria.
With the information that we get. Good job. Okay, so let's read the whole question in its entirety. A 45-year-old woman had a choking episode 3 years ago after eating a salad. Since that time, she has been afraid to eat a wide range of foods, fearing that she will choke. This fear has affected her functionality and her ability to eat out with friends and has contributed to weight loss. Which diagnosis best fits this clinical picture? What key words can we pull out of this?
Choking.
What, Quinn?
Choking.
Choking. What else?
Fear?
Afraid. Oh yeah.
What?
I said afraid. Krista said fear.
Shows up twice. Yeah. This is a big one. Because what we know to be true with the DSM, when we're making a diagnosis, is this thing, this fear, affecting our lives, right? It has to have some effect or impact on our life. And it says it has affected her functionality and her ability to eat out with friends and contribute to weight loss. Okay. All right. So our answer options are bulimia nervosa, schizophrenia, avoiding restrictive food intake disorder, or binge eating disorder. What two can we get rid of?
A and B.
A and what?
B.
B? Okay. Why are we getting rid of A?
Bulimia is like when they throw up the food. And hers isn't necessarily that she's throwing up or trying to lose weight. It's strictly out of fear. And schizophrenia is like hearing, seeing, and feeling things. And I mean, if she had like maybe a somatic delusion that happened, but it didn't say anything to give us an indication of a delusion.
Does anyone have anything different about the A or B, or want to even add about why you got rid of A or B? Are we already putting our answer in there? All right, Katrina's like, I know the answer. So Katrina, I hadn't heard from you for a while. You out of C and D, or C and D, avoiding restrictive food intake disorder or binge eating disorder. You decided to pick C. Why did you pick C, Katrina?
Actually, that was all about eliminations. So,
Good.
like she had said, no, it wouldn't be bulimia. I can't say the word, but and schizophrenia, the same thing. It doesn't have any schizophrenia characteristics. And binge eating means she would eat a lot, right? So I just did a whole bunch of eliminating and picked that one.
Good job. I like it. That's what worked. Good. All right. Did everybody put their answer in? It looks like we did. And it looks like we all agree. Let's see. C. Good job. Have you guys heard of avoidant restrict? Let me see if I can see you guys. Have y'all heard of avoidant restrictive food intake before? No? Okay. So again, I thought you did, Jackie. But for those of us who had not heard of it, even though that's the right answer, and that's something, I still want you to go back. I want to challenge you and go back to look it up. Okay. So just so you can have it in your frequency, in your energetic field. Okay. Explanation: food avoidance or restriction may also represent a conditioned negative response associated with food intake following or in anticipation of an aversive experience, such as choking, a traumatic investigation, usually involving the gastrointestinal tract, or repeated vomiting. The terms functional dysphagia and globus hystericus have also been used for such condition. You guys can find this on page 335 of your DSM-5TR. Okay, please go back and look at it. Who has their DSM on their desk? I always say, have it near you. I don't even have mine on my desk. I need to practice what I preach. Good job, Jackie. Yes, I love it. I need to practice what I preach because mine is not in here. It is in my, y'all want to know where it is? It's in my bathroom because I read it for fun. Bathroom, but I need to put it on my desk. All right. Does anybody have any thoughts or questions about this particular one?
Can I ask a question about the DSM?
Yeah.
Well, kind of a question. So I have the desk reference, which if you guys, it's like $12 on eBay. Go get it. It summarizes all of the diagnostic criteria. When we're studying, should we pull out the big one or is it okay to use the desk
Oh,
reference?
that's perfect. Yeah.
Because
And
yeah,
again,
this
it goes back to, it goes back to what I don't remember which God has said it. There's no way to be able to prepare for everything that's in there and getting that 1,000-page book is, but if you have a summarization of all the big stuff, I think, and if you're able to find that avoiding restrictive food disorder in there, then you should be good to go. I also want to say, just as a reminder, there's 3 things I always tell people to have on their desk, right? The DSM-5 TR, which is our latest volume of the DSM. And again, get the edition and or copy that works best for you. The pill book. Jackie, you got your pill book? Let's see it.
it is right over here on my bookcase. No, I lied. It's in my bedroom because I was reading it last night.
Is it in your bathroom too? Yeah. And get the latest edition of the pill book. I want to say it's less than $10 on Amazon. So it's called the pill book. It's really thick, short, white book, has pills all over it. Less than $10, probably $7 on Amazon. New editions come out all the time. Even though we have heard that there are not a lot of questions about medication on the test, I think as a clinical social worker, hell, as an LMSW, our job is to explain the side effects of the medications our clients are taking. We need to be able to help them and educate them. And the pill book to me does a really, really good job of quickly being a source for us to go to look and say, what, somebody gave me a new medicine just yesterday. The Napazil is for Alzheimer's, and I had not heard of it. And I looked it up in the pill book yesterday after our session because it's not on my desk, even though I say have it on your desk. But I did look it up, and it was in there and gave me some more information so that when we have our next session, we can talk about how this medication may be impacting her mama who is diagnosed with dementia. So have the pill book. Yeah, you can go online, but we're nerds. Y'all are here on a Saturday. Get the pill book. Then the third thing I always suggest people get, or social workers have, clinical social workers have on their desk, is the code of ethics. I say spend the $7 with the NASW and let them send you the pamphlet of the NASW code of ethics. Some of our last questions in today's study session are ethical questions. Have the code of ethics available to you in a paper copy, just so you can just easily read it and refer to it as quickly as possible. Okay. Crystal, what book you got there, darling?
I had my baby go get my book, my pill book.
Her pill book. I love that you made your baby go get it. She's like, I got
I
your
was like,
pill
go
book,
get my
mama.
book.
I love that. That's awesome. Good job, baby. Good job. All right, so let's keep on going, y'all. We're doing good. Your best next course of action would be, wow, your best next course of action would be. What's standing out with that question, Stem?
Best.
Best and next. We got to pick the best and then whatever the next course of action would be. Yeah. Let's read the question in its entirety. You are in your 4th session with a man who is 32 years old. I'm going to assume that has been married for 6 years. He and his wife have 2 small children. He states to you that he recently had a homosexual experience and now realizes that he has been gay all of his life. He wants to talk to his wife, but he's afraid she will become angry and he will not be able to see his children. Your best next course of action would be, What are some keywords in this question?
Fourth session,
Why is that important, Glenn?
because it's not a new client. This is a client that you may have rapport with.
Good job, Glenn. Good job. All right. What else?
He's afraid to talk to the wife
Mhm.
because of the repercussions.
Good job. All right. Good job. Let's look at what the answer options are. Help the client plan for any upcoming legal actions. Tell the client they should remain in the closet until society is more accepting of their lifestyle. Explore with the client the possible outcomes of his revelation and the possible issues he will face in the future. Explore with the client whether the single experience is worth giving up his marriage. What are two that we can get rid of?
A and B,
A and B. Why are we getting rid of A?
because that's out of our scope. We can't help them prepare for that.
Are you saying
And
that with A? That's
I'm
out
saying
of
that
our
with
scope?
A, because we don't even know, and we don't even know what the legal action is going to be. So how can we help them prepare for any kind of legal action?
We went
Anyway,
all the way there with our client. We
yeah,
went all, yeah. Good job. Why are we getting rid of B?
because first of all, that term is so old, remain in the
Right.
closet, and we don't dictate how what type of how he wants to live his life. So
Perfect. All right. So we left with C and D, y'all. What is the best answer option out of C and D? Put it in the chat for me. I think we're all on the same page. Does anyone want to explain to me why C is the best answer?
Well, I eliminated D because he already told us what he have came to terms with, which is he realized that he has been gay all his life. So we can't just explore with the client whether the single experience because we have to give the client self autonomy to choose and do as
Good
their
job. That's it. Perfect. Perfect. This is a great idea. The road he chooses to take must be his own, but your role is to help him look at all aspects of the situation and make a decision with as much consciousness as he can bring to bear on the situation. A is incorrect. This is definitely not our role. Do not go down this path. You could accidentally end up practicing law without a license, which is often a felony. Krista said it best. This is out of our scope of practice. B is incorrect. Never give this advice to a client. In fact, it's best to never give any advice to a client. And then D is incorrect. Exploring is good, but this type of exploration is judgmental and biased towards staying in the relationship. Y'all saw the bias all up in that question, and we stayed away from it. Any thoughts or questions about this one? All right, I'm going to ask, can I get a volunteer to do our format for this next one? Just so I can take a break. Anybody?
I'll do it.
Jackie? Okay, Krista, thank you. I saw somebody's hand move. I thought, so Krista, I'm gonna go to the next one. It's on you, babe, okay?
Am I reading or breaking down the question?
You are doing what we've been doing.
Okay. What is the question? Of the four overall ethical domains below, which one does not apply to the social work profession? So I guess if I'm Renita, what are the first things we see in the question?
does not is in all capital. It's capital. So
Does not.
we're eliminating something.
Yeah. So with that, that means it's only one answer that would be wrong. So we'll be looking for the code of ethics. So things we can take from the code of ethics. What else do we see from that?
Social work profession.
Mm-hmm. And so we're also talking about the values. So what values we hold to be true? Which two can we eliminate? Okay. Well, which two can we say are values and ethics?
We can keep D, behaviors of the client to the professional, and I'm thinking B, due to
Right.
like collaboration and things like that. I'm probably wrong, but I'm gonna keep B and D.
Okay. Yeah, so when we think about code of ethics, we do have an obligation to be respectful towards our colleagues and working professionals. Like, even if we suspect them doing something wrong, we have to go to them first. So that is one of our behaviors. And then D is pretty client-centered when we're talking about social work. Does anybody disagree with Quinn?
Can I challenge D? Because we're looking at our code of ethics, how we're engaging in our professional standing, and D talks about how the client, behaviors of the client to the professional. And we really, right, if clients have self-determination, they can do whatever they want. We still have to work within our ethics, but we don't necessarily talk about the behaviors of the client, at least from like an ethical scope.
Right. Would the just challenging that, not saying that's wrong, I like that, but do you think we would involve like if there are harm to self or others?
That falls under a duty to warn. I don't know if that falls under ethics.
All right. Okay. So with that said, it doesn't look like anybody said, I think A or C. So we can put our answers in the chat.
I love it. And Krista, I was looking at your face. You were just like, I don't know that. All right. Thank you, Carissa. The answer is D. I don't even have it. The correct answer is D. This is not ethical concern of the social worker. And I'm going to go, I think why it's D is exactly the reason Jackie said. These are all social work stuff. This one is client centered. Does that make sense? Yeah. Okay. Anyone have any? Because I can see a couple of y'all's faces. Do we need to have any dialogue about this? Or you getting that this is all social work ethics? This is not. This is clients. It's exactly what Jackie said. Okay. Thank you, Carissa. Darn. Yes. Being brave. All right. Y'all are doing good. I have no idea what time it is, y'all. What time is it?
3:21.
Oh, we're so good. Okay. Thank you. What is the appropriate action for this clinician? When we read the question stem, what stands out the most?
Appropriate.
Mm-hmm. Something's appropriate. That means other things are not. Are we kind of getting the swing of this? Something's appropriate. That means the other three may not be appropriate. Does that make sense? Let me see if I can look at y'all's faces. One thing is appropriate, the other three are not. Okay? We got that? Okay. When reviewing a patient's responses to items on the World Health Organization Disability Assessment, the WHODAS 2.0, the clinician asks the patient, how much time did you spend on your health condition or its consequences? The patient answers, hardly any. The clinician who has treated the patient for several years is surprised to hear this because she is quite certain that the patient spends most of the day dealing with health concerns. What is the appropriate action for this clinician? What are some of the key words out of the question that we are asking?
The physician has treated the patient for several years.
Mm-hmm. Mm-hmm. So again, it goes back to, I think something Quinn said, this is not a new patient. We know this person. Okay. So now we're going to read the answer options. Actually, I'm going to read the whole question in its entirety. Remember, 3 are not appropriate and 1 is. Okay. When reviewing a patient's responses to items on the World Health Organization Disability Assessment Schedule 2.0, the clinician asks the patient, how much time did you spend on your health condition or its consequences? The patient answers, hardly any. The clinician who has treated the patient for several years is surprised to hear this because she is quite certain that the patient spends most of the day dealing with health concerns. What is the appropriate action for this clinician? Is it to confront the patient about the clinician's concern and ask the patient to reconsider? Is it record the patient's response as is and score accordingly? Is it indicate on the form that the clinician is making a correction and revise the score? Is it attempt to obtain additional information from family members in order to clarify the discrepancy? What can we say is inappropriate? Give me 2 that are inappropriate.
But I really want to do it. I felt it like, oh, I would definitely want to confront, but I know it's appropriate. Okay.
Can I challenge that answer?
Yes, of course.
I wouldn't want to eliminate ages yet because even if we confront, I don't think it's confrontational. Especially the client being someone that I've seen for several years, and confront doesn't always have to be negative. So can we hold on to that answer?
We can, certainly can. So we still haven't figured out what would be an inappropriate action
What
yet.
about D?
Yeah.
What about who?
D.
As in dog?
Yes.
Attempt to obtain additional information from family members in order to clarify the discrepancy. Why are we getting rid of that one?
I'm thinking we would have to have a release. What if that our client wouldn't want us to get that information from them? And also, even though we know that it's a I'm tearing the word up, but that word, the clients, we still would confront the client about information they're withholding or not being upfront about their health problems.
Okay. Anyone want to challenge that one?
I feel like at least when I work, we can obtain information, we just can't release it.
I want to keep A because she has knowledge. The clinician has the knowledge that the patient is doing these things. So I would keep A.
I guess my problem is, well, at least for some of my assessments in my job, some of them clarify and then some of them like say only put report what the patient says or client says. So is it, with this question, is it important to know what the HUDAS is?
Is that a key word? Good job, Carissa. What other thoughts are we having, y'all?
So I think the answer is B.
Why do you think the answer is B?
Because regardless of all the other ones feel inappropriate. How about that? If we're looking for what's most appropriate, if my client says that their PHQ-9 is a 20, and I'm like, I don't really think it's 20, but that's what they're reporting, then I need to report that score and that response. And I can write something underneath that if I want to. Or I can go back and have a conversation after I've recorded it. But they're self-reporting at that point. So their self-report is what I'm going to measure up. I might counter back after the fact and confront them about my concerns because we've been working for a really long time and you're not putting time and energy towards the treatment. Like, what are we doing? Do we need to assess treatment plans and things of that nature? I'm not going to mess with the score necessarily and go, well, I know you don't really mean this, so let me change this here or move this here. And I can't break HIPAA and talk to my clients' family members or friends unless they give me permission. Unless it's like, hey, do you mind if we bring your wife in and have the conversation? But generally, that's kind of inappropriate depending on what the diagnosis is. So I feel like B, if we're looking for what is the most appropriate action for the clinician, that's the most appropriate. And I could be off on this, but if we're just going textbook,
Well, I think what Carissa said, I don't even know what this is, the HUDAS. So I think as I think of my answer, I'm gonna take you my answer back because I don't even know what HUDAS is. So I need to know what that is.
It's a disability assessment schedule. So it's a disability. Well, you do need to know what it is, yes, but let's just put our answer options in the chat and then have dialogue. I love that we're getting all these different answer options. All right, let's see. I can get there, y'all. It is C. And Jackie, you almost said it too when you were like, I would. So the HUDA should be seen as a collaboration between the clinician and the patient, and the clinician should not blindly record patient responses to the various questions. If the clinician, using all available information and clinical judgment, believes an answer to be inaccurate, the clinician should record a correction to that item, score, indicate the revised score in the raw item score box. The clinician is asked to review the individual's response on each item on the measure during the clinical interview and to indicate the self-reported score for each item in the section provided for clinician use only. If the clinician determines that the score on the item should be different based on a clinical interview and other information available, he or she may indicate a corrected score in the raw item score box. So I think two things. One, like Carissa said, different assessments allow you to do different things. So apparently the HUDAS does let you and has space for writing in, but also I thought with if I can go back, this was the clinician who's treated the patient for several years is surprised to hear this because she was quite certain that the patient spends most of the day dealing with health concerns was key in this particular question. Tell me what you guys are thinking.
I guess I was wondering why that would be the key, because I know sometimes in the question they'll put something in there to kind of throw you off, so you can but you actually have to find a thing in there. I understand what you're saying, but I know sometimes it feels like it's so much information overload that's not even relevant to the question.
You're right. You're absolutely right about that. And again, there's no way to prepare, like, what the hell is the HUDAS? I liked it because it sounded like New Orleans, who dat, but what, you know, who's gonna, unless you're in this particular world, you may not ever use a HUDAS, right? One of the things too that I'm hearing you guys say repeatedly is in my, you know, as a school social worker or in my role as and I'm hearing that a lot as well. So I don't know what I was going to say about that. Y'all, the thought went right out the window. So maybe we'll be able to come back to it. Jackie, you had unmuted. Were you going to say something?
Yes, it's not productive. I just feel like that's wrong. I feel like if my supervisor knew that I had a raw score and I switched it around, I would be in trouble. Like just from a professional standpoint. So reporting the raw score and then having a conversation with them, or right, maybe we don't understand, let's tease it a little bit more, and then documenting that makes more sense to me. And I just feel like some of these questions I can look and go, okay, well, on the test, yeah, that makes sense, but in real life, I don't know if we
Right.
actually move like that, and that's kind of frustrating.
I remember when we were taking it, or when I took my elements debut, because I didn't have so much experience in the field, they told us that we don't think in accordance to our job. And I think that also is kind of what threw me off with the question. But even if I didn't think about my job, assessments kind of come in that, is it like what we're supposed to put? Is it collaboration? So I don't know. I feel like in this question, we really had to know what the HUDAS was.
I want to challenge you guys, go look it up too, right? And I put on here because I went and looked for scoring and interpretation guidance for the DSM-5 users. I think I told you guys I made some of these slides a couple of years ago. So check the page, but it's going to be near this page. So go back and look if you have the full DSM. All right, I think we only have 2 questions left. Are you guys good to go for the two more questions? It might be 2. It might be, I don't know how many questions. We got just a few more questions. Here we go. Your first intervention should be, what's standing out with the question stem?
First, an intervention.
Why is intervention important, Jackie? That's a great one.
Because there's going to be multiple actions or interventions that need to be done, but there's one that you want to do first. That's the maybe most important or most appropriate.
And I want to say intervention is not, we're not assessing, we're not gathering it. We are doing a modality. I think knowing that intervention is in there is very, very important. And it's going to be the first one we do. All right, so let's see what the question is. Terry showed up for his appointment very upset and anxious. She stated she is frightened because she has begun hearing the voices again, the voices that tell her she should kill herself. She has been hearing these voices for approximately 5 years and has 2 prior suicide attempts over this time. She states that the voices have become stronger over the past week. She says she has received a call from her mother that a friend from high school had completed a suicide attempt. Your first intervention should be, what are the key words?
She's hearing voices about self-harm, so hearing voices that telling her she should kill herself.
And what goes along with that?
That these voices are approximately 5 years since the last suicide attempt. Am I reading that right? Hang on a second. She's been hearing the voices for 5 years.
Yeah. I want to also say 2 prior attempts in the last 5 years. That's very important. Okay. All right. So your first intervention should be complete a depression screen. Your first intervention should be discuss the need for immediate inpatient hospitalization. Your first intervention should be begin a complete suicide risk assessment, or your first intervention should be ask Terry about her current medication compliance. What two can we get rid of?
B and D.
Why are we getting rid of, and is it B as in boy?
Yeah, B as in boy.
Why are we getting rid of B?
Because we can't create an intervention if we don't know the level of risk, and everything does not require, just because she's having the command hallucinations doesn't mean that she's going to act upon them. I don't want to keep going because I'll give my answer.
You're doing good though. Why are we getting rid of D?
I know in one of the screenings
Mhm.
that it already kind of asks that. So if we do what I'm thinking the answer is, we'll already have the answer within that.
Because this isn't, again, we're not assessing. This is the
Mhm.
intervention. And so we should already have that in our assessment. Is that what I'm hearing you say, Carissa?
Yes.
All right. And again, if this is an intervention, where are we got A and C left. What are we doing? Oh, I love her putting the answer in the chat. C, 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 C. A. Did somebody say A or is that from last time? No, I lost my space. I don't know what time it is. 3:38. Okay. C, C, C. Okay. Begin a complete suicide risk assessment. Who wants to tell us why we are picking C?
Because just because she's hearing voices telling her she should kill herself doesn't mean that she has an intent or plan. And we want to see if there is an intent or plan. Even though there is a history, we want to double check that she hits the criteria.
Perfect. Let's see what we got, y'all. Good job. Let's just pause and be like, thank God, because especially after that last one. Good job. The correct answer is C. In the realm of suicide risk, the loss of a friend or family member is a serious risk indicator. The shorter the time between the known suicide and the present, generally the greater the risk. This one fact, along with her continual cycle of hearing voices, is enough to put you on high alert. A is incorrect. Safety and self-harm are the greatest problems right now. Underlying depression should be expected. B is incorrect. You are jumping too fast here. It should be TOO. You should be aware of this possibility, but you need to review all risk and protective factors in a complete suicide risk assessment. And D is incorrect. Nothing in the question deals with medication. When answering the questions on the test, deal only with the information given in the question. Who wants to, do y'all have any thoughts or words about what the rationales are with that? Feeling good. All right. What is the best ethical response? Love, we're getting to ethics. What is the best ethical response? What comes up?
The code of ethics.
Code of ethics and
Yes.
best. Good job. A hospital social worker is asked to meet with a patient who has just been informed of a terminal diagnosis. The patient says, I don't want any of my family to know yet. I need time. The physician later tells the social worker she already informed the patient's family. What is the best ethical response? What key words can we pull out or phrases?
So we're working with a terminal patient whose self-determination wants privacy to process what's going on. And despite that request, the physician has kind of broke that self-determination, has already informed the patient's family.
Okay. A through D, support the physician's actions since the family support is critical. Advise the patient to speak to hospital administration. Discuss the situation with the physician and advocate for the patient's right to self-determination. File an ethics complaint with the hospital's compliance officer. What can we get rid of?
A for sure.
Why are we getting rid of A?
Because supporting the physician's actions when he directly, based off our scope of ethics, where self-determination and client-centered is so important, to support the physician's actions of kind of disinvalidating the client's wishes isn't within our ethics.
Does anyone have anything different from that?
I'll get rid of C as well because it's too late. They already violated it, so it's too late to really try to practice it at that point.
Does anyone disagree?
I do kinda. I'm guessing I'm coming from because I don't know, because I read it as discuss the situation with the physician, which we should approach this physician to talk about the client and to advocate for the client. And I'm thinking then we would do a report to the compliance officer. But I could be wrong.
Quinn, I'm going to stick with what you're saying. And I think the two of you read it differently. And Quinn, when you read it, I'm seeing the code of ethics so clearly. We want to go to our colleague first, right? Like, dude
Right.
or ma'am, I don't know, physician person. Why did you do that? I'm going to tell you the patient didn't want that done. Going to the physician first and then advocating for the patient's right to self-determination. That is, especially when we're looking at the other options, because if I get rid of C, am I going to advise the patient to speak to the hospital administration?
Yes,
Is
but
that going to
not
be my best? Yeah. And then am I going to file an ethics complaint without having spoken to the physician first with the hospital's compliance officer, knowing that my code of ethics says to speak to my colleague first? So when I'm looking at the other choices, even though it's already been done, I'm still gonna go, I think, to the physician. Katrina, you want to say something, babe?
I was gonna say I think I read into it incorrectly because, like I was saying, I had jumped ahead. Like, well, it's too late to go do that now. But when you break it down like that, I can see where you guys are coming from.
I guess my question is if it's already been done, what are we advocating for at that point?
I'm advocating then for me, well, and this feels like a read into it, but one, with the choices I have, I'm not for me, Renita, I'm not a fan of these three choices. But then to answer your question, Carissa, the patient's right to self-determination, I'm advocating, okay, now that even though you've told the family, what are the next steps the patient can do as far as how much more they want to tell the family or what are the patient's next steps, I guess, in order to keep their self-determination. Carissa, what would you pick? What are you, well, why don't we just say it all in the chat? What would be y'all's answers? And then let's look at what your rationales would be. You want to go ahead and file the complaint, okay? C, then D. You can't do that, Jackie. You gotta pick one. Carissa, talk to me about why you're going to go straight to file an ethics complaint with the hospital's compliance officer.
Well, it asks what's the best ethical response, not like the steps.
Mm.
And because ethics have already been broken, and at least in my head, there's a problem. And then I feel like with B, even though I'm gonna advise the patient to speak to the hospital administration too, I still need to file the ethics report anyway because they did break something. And maybe they'll be reprimanded with, I don't know, CUs or,
I'm going to pick C, but let's see, okay, if I can get there. It is C, and I get what you're saying, Carissa. I'm trying to move so I can see the rationale. Social workers are ethically obligated to advocate for client self-determination and privacy. while the physician's actions may be legally, what does that say? Because I can't read it, sorry.
While the physician's actions may be legally permitted, that this raises ethical concerns. Let me keep reading.
Yeah, go ahead.
A direct conversation is the most professional and appropriate first step.
Why this is correct. This aligns with two core values from the NASW Code of Ethics, self-determination. Clients have the right to make decisions about their lives. We already know this. And client confidentiality. Social workers must protect private information and advocate for the ethical handling of that information by others. The physician may have acted based on medical norms, because that's what I was thinking too. Physicians have a different code of ethics, but I don't know if that has anything to do with this question. But medical norms or legal leeway, for example, if families involved in care, but the social worker's role is to center the client's express wishes and bring ethical concerns to light professionally and directly. This step also models interdisciplinary collaboration, not conflict. Let's go back. B, deflects responsibility without advocating. And D, may be appropriate eventually, but not as the first action. So which one did you pick, Carissa?
I picked D. Because even in the answer, it says not as the first action, but we're talking about best.
Mm-hmm.
So I guess I'm still confused there. And then also, can you go back to the answer screen?
Mm-hmm.
And then in that, I guess when it says, e.g., if family is involved in care, like if that's example, but I thought we weren't supposed to put anything into the narrative that's not there.
Mm-hmm. Mm-hmm. We're not. We are not.
So we're using e.g. just simply say as an example.
That's what EG says. But y'all help me out with this one.
If I could say something, the way I look at it is, if you're focusing on the here and now, and you're focusing on how you can help the patient in that moment, saying that you're gonna go to the board is not helping the patient in that moment. So that's the way I looked at it.
I think I could add on to we never stop advocating for a client, even if we think it's the last if it's something that has already been done. So just reading the question in the code of ethics, it does say go to your colleague. It doesn't say skip going to your colleague and go straight into action and saying, hey, this is what I'm gonna do next. So that's why I pick C, if that helps.
Sometimes, Carissa, it'd be like, I just don't know. I would have picked something else. And that's part of this, right? That's part of it. That's why you can get a certain range correct. And these ethical questions are so subjective sometimes, I think, too. And we have one more ethical question. So let's see what we get. I think this is ethical, if I remember correctly. What is the social, I don't know if it is, y'all. Don't take my word for it. What is the social worker's most appropriate response? So we got this most thing again, and again, the appropriate. So that means when I see most appropriate, it could be another appropriate response. But then that we got to pick one of the most appropriate versus the least appropriate. So there could be multiple appropriate responses. And again, that feels so subjective, right? Like Carissa is kind of implying with that last question. So a social worker in a residential substance use facility notices that one of the residents who recently relapsed is being excluded by peers in group therapy. The resident reports feeling unsafe and targeted. What is the social worker's most appropriate response? So what are some of the key words in this question?
Residential,
Mhm.
substance use.
relapse, exclusion,
Group
and feeling
therapy.
unsafe, and group therapy, yes. Unsafe and targeted.
Good job, y'all. So I'm gonna read it all together just because I got distracted. A social worker in a residential substance use facility notices that one of the residents who recently relapsed is being excluded by peers in group therapy. The resident reports feeling unsafe and targeted. What is the social worker's most appropriate response?
I
Is
forgot
it to
to add group therapy. So we
group therapy? Group therapy is a key word. So is the most appropriate response to facilitate a conflict resolution session with the resident and their peers? Is the most appropriate response to meet individually with the resident to assess for safety and coping? Is the most appropriate response to remove the resident from group until tensions decrease? Or is the most appropriate response to encourage the resident to build resilience as part of recovery? Woo! What are we gonna get rid of?
C.
Remove the resident from group until tensions decrease. Why are we getting rid of that one?
Because we at least need to know the reason that tensions even flared up. I don't know. When I think about this question, I'll immediately jump to the Schopenhauer cure. And how he did something when like conflict arose. So that's just what I thought about.
I love that you jumped to our book as a plug for the Goddesses Social Work Book Club and how reading that book is helping Carissa get the right answer to this question.
And I think I agree with Carissa. And Carissa, I thought about the book too, actually. So I'm gonna go with because if you remove him, there's still problems. It's really not gonna help what he's experiencing. So I think we can remove C.
And so I love that you thought about the book too. Y'all, that is so awesome. That's making my heart so happy. And again, I feel like every clinician should read the Schopenhauer Cure, especially if you're going to participate in group therapy. So, and it's on Audible, and I enjoyed listening to it as much as I enjoyed reading the book. And one of the things I was going to talk to you guys about is our next book that Krista picked out for our book club, and you have all the way to September to read it, but we'll talk about that at the end. All right, so it sounds like we're getting rid of C, and we're thanking the Schopenhauer Cure for helping us get rid of that one. So we have A, B, and D left. What other one can we get rid of?
What about B?
What about which one?
B as in boy.
Oh, I was having a moment. Meet individually. Okay, meet individually with the resident to assess for safety and. Why are we going to get rid of that one, Quinn?
Because I'm thinking A, because when you're doing group therapy, you have to facilitate open communication. And it's like if you go straight to B, it's like you singling. I don't know. I'm just thinking about facilitating the open communication in group therapy. So I may be wrong. I have no idea.
Carissa, you have a thought?
Yeah, because it says the resident feels unsafe, and when we're dealing with I think social work, we're supposed to consider safety first. So I haven't ruled out B, but that's not also my final thing right now. But I kept B because of the safety.
Carissa, I want to agree with you on that. I don't know what the answer is, but this is the only one that has safety and safety. I think there's something to that. So I want to hold on to, because safety is always going to be our number one answer. If there's a question about safety, safety is always going to be the first answer. Does that make sense, you guys? Safety is always going to, I don't even know, I don't have a acronym or anything to give you. Just know that if there's a question about safety, safety is always going to be probably the answer. But so can we hold on to B? We'll hold on to B. So give me another one to get rid of.
I would
put-
get rid of D. Oh, I'm sorry.
No, go ahead, because I was gonna say the same thing, Jackie.
Okay. I would get rid of D because that just means maladaptive every which direction. Doesn't teach him conflict resolution, kind of isolates him. We're kind of setting him up for relapse if we do D.
I love that. I would have got rid even the credulousness of when I read that. Encourage the resident to build resilience as part of recovery? Really? Okay. So we've gotten rid of C and D, and we have two answer choices left, which are A and B. And we've already talked about safety and safety, safety and safety. So what could potentially be your answer choice in the chat, please? Oh, the name of the book is The Schopenhauer Cure. I always spell it wrong. Does anyone, Carissa or Crystal, y'all know how to spell The Schopenhauer Cure?
And I know it starts SCHO, I think.
I'm just going to do my best in the chat. And it's by Irvin Yalom. It's a, Carissa said that it was slow read at first. She didn't say it got good, but she just said it was a slow read. And
It started a little slow, but it got good. It's
it did.
good.
Oh, thank you, Jackie. Yes, thank you, Jackie. Good job. Yes. And if y'all decide to read it and want to do a part 2 of the book club, I'm always down for that. I am always down for that. All right. So let's see. It looks like if I can go to the answer choices, we all pick B. Okay. Let's see what it is. It is B. And my thing is blocked, but it says this is the best for steps. The client just relapse and feels unsafe. You must something here. Emotional and psychological safety before anything else. A one-on-one session allows the client to be heard and supported. It also helps the social worker assess risk, stability, and coping. Facilitate a conflict resolution session with the resident and their peers is not the right first step. Conflict resolution can be helpful later, but not now. The client feels unsafe and vulnerable. Asking them to face the group too soon could be re-traumatizing. It may cause more harm than good. Remove the resident from the group until tensions decrease. This may seem protective, but it's not the best choice. Removing the client can make them feel punished. It may increase their sense of shame and isolation. The client should not be excluded without first being supported. And D is incorrect. Encourage the resident to build resilience as a part of recovery. This response is dismissive. It ignores the client's real concerns, telling them to build resilience, shifts the blame onto them, and may make them feel unheard or unsupported. Clients need safety, again, that word, and validation before encouragement. Safety is always going to be the answer choice, y'all. I'm just FYI, go with safety, okay? I think we got one more question. Are we at time though? I don't know what time it is.
It's 4.
Oh, is it? Oh, okay. Final thoughts. I love essential oils. Use it. Lavender, rose, ylang ylang, I think it's called. Use it for anxiety. You can put it in your diffuser. Make sure you are practicing and studying outside of our time together. And obviously, I'm pushing Circle, and hopefully, we'll be uploading this into the Circle. So, what if you haven't joined Circle? Ongoing learning, community connections, sacred reflections. I'm even going to post something after this in there as well. And Krista, thank you, darling. Our book for the Guys of the Social Work Book Club is What Happened to You by Oprah Winfrey. I love that it's called About Understanding Resilience. So that is what we're reading. It's on Audible. If you are into Audible like I am, and or Libby, you can find it in a lot of different places. And so you can already see just by reading the book, Krista and Carissa are like, oh, I know that answer because we read about it. So learning can come from all different formats, including reading. I think reading is important because it helps with your documentation, y'all. It helps you become a better social worker. So while you are in the supervision, if you can read along with us, I think it will make you feel a lot more confident and comfortable and help diminish imposter syndrome. And we hold a space for you to do that, okay? Any thoughts or questions about our time together today? Are you going to come back to the next one? Yeah, good. All right, take it with you. Pull out that DSM, look at the stuff we talked about. And Jackie, I'll stay on for just a second longer, okay? I'll see you guys next time.